guys, in this video we're going to be having a discussion about the most important images pertaining to the topic of the hepatobiliary system. Let's get started. Looking at this particular image is going to be suggestive of the condition that is mentioned over here, that is going to be acute hepatitis. Now the moment we talk about acute hepatitis, it is going to be characterized by the fact that the hepatocytes are going to be all swollen up. I mean, you can appreciate over here the fact that this particular hepatocyte is swollen up. So that is what is going to be given the name of ballooning of the hepatocytes. You're going to be having the presence of a central nucleus, and then you're going to be having the presence of a cobweb cytoplasm. One of the recent exam questions that they gave to you was with respect to how we make a diagnosis of acute hepatitis in a patient suffering from hepatitis B infection. So that is going to be indicated with the help of the presence of surface antigen, and along with that, high infectivity is denoted with the help of the presence of HBe antigen. So that combination, if present serologically, is going to be suggestive of the presence of an acute infective state of hepatitis B patients. Incidentally, what can also be appreciated over in the same slide is, if you pay your attention to this particular area, you get the presence of a dark eosinophilic structure over here, and this particular structure is what is going to be given the name of apoptotic body. Why exactly do we need to talk about apoptotic body over here? It lies in the fact that this particular example is going to be a very typical example that is given in the exam, that apoptotic body is seen in case of an individual suffering from viral hepatitis. Of course, we have had a discussion about apoptosis in detail during our discussion of the cell injury chapter, wherein we talked about the intrinsic and the extrinsic pathway. We did talk about the fact that there are certain physiological examples and certain pathological examples, but this important example of a structure is what you need to keep in mind so far as an apoptotic body is concerned. The apoptotic body in case of viral hepatitis is also being given the second important name, and that is what the examiners love to go after time and again in the exam. That's a simple one-liner question. It has given the name of a councilman body. So that is what we need to be having an idea so far as acute hepatitis is concerned. Now this is another important example of a eosinophilic structure that you are going to be finding in association with apoptosis. So this is what is going to be given the name of apoptotic body, or as I did make a mention of the fact, that is what is also being given the name of a councilman body. So this kind of a structure is what you need to be familiar with over here. And whenever you're going to be talking about apoptosis, this is going to be associated with the presence of loss of the nuclear material right up over there. So that's the two important images I wanted you to have an idea about so far as the viral hepatitis is concerned. Talking about the next important example of an image, this is what is going to be suggestive of a condition that is going to be given the name of chronic hepatitis. Now chronic hepatitis, out of the different types of infectious causes of hepatitis, like let me talk about the viruses over here, hepatitis A, B, C, D, E. So we understand the fact that hepatitis A and hepatitis E are the ones which are only and only responsible for causing acute hepatitis, whereas when we are making a mention of chronic hepatitis, that can be seen in case of an individual who is going to be suffering from hepatitis B, C or D. Now one of these subtypes of the viruses is not responsible for causing infection on its own, and that is what is going to be the hepatitis D virus or the delta virus. We understand the fact that the hepatitis B and hepatitis C are quite common causes of development of chronic hepatitis. So far as the chronic hepatitis picture over here is concerned, this is going to be characterized by the presence of the ground glass hepatocyte. So that is what you need to keep in mind over here. I would just make a mention of this particular fact. This is going to be given the name of ground glass appearance. The reason for the ground glass appearance has been asked in the exam earlier, and this is typically going to be contributed by the presence of hepatitis B surface antigen. We also need to be familiar with the fact that sometimes hepatitis B surface antigen is going to be present in the cytoplasm, and it is responsible for giving a hazy appearance to the cytoplasm. What has been asked in the exams earlier, that is being given a special important name. The special important name that you need to keep in mind over there, it is called by the name of Hurdziani cells. So Hurdziani cells are the name of the cells which are going to be infected by the hepatitis B, and particularly because of the surface antigen, you're going to be having the presence of a dull appearing cytoplasm. So you just need to be able to appreciate the presence of a ground glass appearance, the presence of surface antigen, and the Hurdziani cells, which is seen in case of chronic hepatitis. The next important image that we need to have an idea is what is going to be very much suggestive of the fact the patient is going to be suffering from a condition that is going to be given the name of autoimmune hepatitis. Now, whenever we're going to be talking about autoimmune hepatitis, it is going to be having multiple variants, but then autoimmune hepatitis is going to be characterized by three important facts which is seen histologically. Fact number one, you can see the appreciation over here. You can see the presence of hepatocyte which is going to be having the presence of a multinucleated appearance. The other important fact that I wanted to appreciate over here is that there is a presence of a cell within a cell, and that is what is going to be associated with the term, that is what is being termed as emperipolesis. Also, we need to be familiar with the fact that the hepatocytes are going to be having a flower-like arrangement, what is going to be given the name of a hepatocyte rosette formation. So that's a central area, and there you have the presence of the hepatocytes which are going to be appearing themselves or arranging themselves in a flower-like arrangement. So that is going to be given the name of the presence of a hepatic rosette. So one important finding is emperipolysis, that means cell within a cell. Interestingly, you need to remember the fact which was asked to you as an exam question separately. The cell within cell or the emperipolysis is going to be associated with a unique finding that there is a big cell that is going to be eating up a smaller cell, but both these cells are going to remain viable. Please be familiar with the fact. The second important thing that we have over here is that hepatocyte rosette formation, and a third important thing that we find over here is that there is the presence of the plasma cells and the lymphocytes infiltrating at the level of the limiting plate. So this is what is going to be given the name of an interface hepatitis. So presence of these three important histological findings, that means the presence of an interface hepatitis, presence of emperipolysis, and the presence of a hepatocyte rosette formation is quite suggestive of something like autoimmune hepatitis. The next important thing that we need to have an idea is that there are going to be three important subtypes of autoimmune hepatitis. The type 1 autoimmune hepatitis is going to be characterized by the fact that patients over here characteristically are going to be having the positivity for anti-nuclear antibody, and sometimes there is going to be positivity for anti-smooth muscle antibody, which is given the name of asthma, anti-smooth muscle acting antibody. In contrast, when we are talking about a patient who is going to be suffering from type 2 autoimmune hepatitis, these are the patients who are going to be having the presence of anti-liver kidney microsomal antibodies, so LK1 antibodies. And when we are talking about the type 3 autoimmune hepatitis, this is going to be associated with negativity for anti-nuclear antibody, but still there is going to be positivity for what is going to be given the name of the soluble liver antigen. So you need to be familiar with the three important subtypes and the different types of antibodies that are going to be seen in each of them. Not to forget the three histological findings that we just made a mention of. The next important image is going to be suggestive of the fact that there is going to be replacement of the hepatic tissue with the fibrotic bands, and that is going to be given the name of liver cirrhosis. Now, as and when we are going to be making a mention of liver cirrhosis, we need to be familiar with the fact that there are going to be two important variants. One in which we are going to be having the formation of tiny nodules, so that is going to be given the name of micronodular liver cirrhosis, and the second one which is going to be having big nodules, which is going to be given the name of macronodular liver cirrhosis. The differentiation between the micronodular and the macronodular liver cirrhosis lies in the fact that if we are going to be looking at the size of the nodules, the size of the nodules over here is going to be less than 3 millimeters, whereas the size of the nodule in case of macronodular liver cirrhosis happens to be more than 3 millimeters. Both of them are going to be having certain common conditions which can be causing them. Say for example, alcoholic liver disease can initially result in development of micronodular cirrhosis. Subsequently, that can result in development of macronodular cirrhosis. However, for the sake of simplicity, I may tell you over here that micronodular cirrhosis is classically going to be associated with the presence of usually the metabolic disorders. On the other hand, whenever we are going to be talking about the macronodular cirrhosis, this can be associated with patients who are going to be suffering from conditions. Say for example, as I just made a mention of the fact, the patients are going to be having the presence of a history of alcohol consumption. So the size of the nodule, that is 3 millimeter cutoff, is what you need to remember for differentiating between the micronodular and the macronodular cirrhosis. Now, one important finding that is loved by the examiners to be asked time and again is going to be the presence of this kind of an eosinophilic band-like structure, which is going to be made up of cytokeratin 8 and 18. And this kind of a structure is what a lot of you should be able to recall, friends. This is going to be given the name of the Mallory-Denk body. Now, Mallory-Denk body is going to be having this kind of an appearance, a eosinophilic appearance. Please be familiar with the fact that it is not an example of a very specific histological finding. So, you can be having the presence of the Mallory-Denk body in multiple conditions. Certain conditions where we have the development of Mallory-Denk bodies can be a patient who is going to be suffering from, let us say, alcoholic hepatitis. You could be having it in a patient who is going to be suffering from alpha-1 antitrypsin deficiency. Might as well be seen in a patient who is going to be suffering from some kind of tumor. Say for example, even the hepatocellular carcinoma can be seen in case of chronic cholestatic conditions. You can have it in a patient suffering from a condition like Wilson's disease. So, a lot of conditions where you can be having the presence of Mallory-Denk body, but the important thing is to be able to identify the Mallory-Denk body and to be able to talk about the fact that what exactly is going to be the composition of the Mallory-Denk body, that is going to be something like cytokeratin 8 and 18. Now, apart from the presence of Mallory-Denk bodies that you could be having in a patient who is going to be suffering from alcoholic steatohepatitis, a lot of these patients could be even having the presence of perisinusoidal fibrosis. Perisinusoidal fibrosis. The moment we are going to be talking about something like a perisinusoidal fibrosis, we need to understand the fact that there is going to be deposition of the collagenous material, which is going to be having a pattern which is going to be reminding you just like a chicken wire fence. So this kind of a pattern is what is being described by the book in the books by the name of the chicken wire fence pattern. And in order to establish this kind of a pattern, the only thing which has to be demonstrated is the presence of collagen over here. As most of you are intelligent enough to understand by this point of time, the demonstration of collagen in a lot of tissues, be it the renal tissue, be it the hepatic tissue, can be done with the help of a stain that is going to be given the name of the Messon's stain. So the Messon's trichrome stain is useful for demonstration of collagen, and that bluish color that you get over here The bluish color that you get over here is going to be contributed because of the presence of this kind of a stain. The next important example of an image is of the commonest reason for development of liver cirrhosis, and this is what I'm going to be talking about over here, the alcoholic liver cirrhosis. So alcoholic liver cirrhosis is what we just need to be familiar with the fact. It is going to be given the alternative name. This condition is also being given the name of Laennec cirrhosis. Grossly, you can be having the presence of the irregular nodules on the surface of the liver. There is going to be replacement of the hepatic tissue by the fibrotic nodules, thereby compromising the function of the liver. At a microscopic level, you are having the presence of that bluish color, which I just explained you 2 minutes back because of the deposition of the collagenous material over here. And there is going to be presence of the regenerating parenchyma of the liver, which is going to be therefore contributing to the development of these nodular structures. So you have the presence of the irregularity or the nodular appearance, which is going to be seen because of the deposition of the collagen over here, and that is what is going to be seen in case of a patient who is going to be having the alcoholic liver cirrhosis. The next important example of an image is going to be characterized by the fact that you're going to be having the presence of concentric rings of smooth muscle deposition that is going to be seen around the bile duct. So this is going to be associated with the presence of the onion skin appearance. The onion skin appearance that you have because of the concentric smooth muscle proliferation around the bile duct. And obviously, when I'm talking about that particular fact, an example of a condition that is more commonly observed in case of males, quite commonly associated with the development of a condition like inflammatory bowel disease, more so ulcerative colitis. The condition I'm making a reference to over here happens to be what is given the name of primary sclerosing cholangitis. The importance of knowing about primary sclerosing cholangitis lies in the fact that because of development of the sclerosis over here, there is going to be a problem in the outflow of bile. So this particular condition is likely to contribute to the development of obstructive jaundice. Now, from the perspective of the exam, definitely you need to have an idea about the concentric ring appearance that is going to be seen over here, the onion skin appearance of the bile duct over here, and this onion skin appearance is not to be confused with the onion skin appearance that you get in the blood vessels of the spleen in a patient suffering from SLE, nor should you be confusing that with the onion skin appearance of the blood vessels that you get in the kidney, which is seen in a patient suffering from malignant hypertension. Another important finding that we associate with primary sclerosing cholangitis is going to be the presence of that patchy appearance or the beaded appearance because of development of that patchy fibrotic area. So this is what is going to be given the name of the bead-like appearance or the beaded appearance on the cholangiogram. So cholangiogram showing you the presence of the beaded appearance is what is going to be seen in a patient suffering from primary sclerosing cholangitis. The next important example of a chronic cholestatic condition about which we need to have an idea is a condition that is going to be given the name of primary biliary cirrhosis. Now therefore the examiners love to ask you the differentiation between these two conditions, as I did make a mention of the fact this primary sclerosing cholangitis was a condition which was having the onion skin appearance of the bile duct, more commonly seen in case of males, associated with ulcerative colitis, is going to be having the presence of P ANCA positivity. In contrast, as and when we are making a mention of something like primary biliary cirrhosis, this is an example of a condition more commonly seen in case of females. This is an example of a condition that is going to be having the presence of an antibody which is given the name of anti-mitochondrial antibody. It can also be associated with the development of certain types of autoimmune disorders, amongst which the important example that is loved by your examiners happens to be given the name of the Sjogren syndrome. I hope you remember the antibodies in a patient having Sjogren syndrome, the anti-SSA and the SSB antibody, alternatively called by the name of anti-Rho and anti-La antibody. Whenever we are going to be talking about a patient who is going to be suffering from the primary biliary cirrhosis, what is going to be seen in case of these individuals is that there is going to be a very important infiltration at the level or the portal tract by the lymphocytes. So this is what is also being given the other important name of, it is called by the name of the florid duct lesion. The moment you see a question in the exam which is making a mention of the florid duct lesion, you should be reminding yourself of the fact that the bile duct is going to get injured because of the infiltration caused by the lymphocytes and the plasma cells. Additionally, what we need to remember over here is going to be a simple fact that whenever we wish to talk about anti-mitochondrial antibody, they can be detected with the help of a special type of a tissue, and the tissue which is going to be used over here is going to be the rat kidney. One of the reasons for that particular fact happens to be that the rat kidney is going to be having presence of a lot of mitochondria. So understandably, anti-mitochondrial antibodies can be best detected over here. So the differentiation between the primary biliary cirrhosis and primary sclerosis is what is going to be extremely important for differentiating between the questions which are going to be based upon some kind of a clinical history and having a common manifestation in the form of development of an obstructive jaundice. Talking about the next important example of an image, this is going to be an example of a metabolic disorder which is going to be characterized by the deposition of that orangish or the brownish appearance of the iron deposition in the hepatic tissue. And as and when I give you the hint that there is going to be an excessive amount of iron deposition over here, you would automatically recognize this condition. This condition is going to be given the name of hemochromatosis. Now, as and when we make a mention of hemochromatosis, let us just remind ourselves of the fact that this is an example of a condition in which there is going to be involvement of the gene given the name of HFE gene. Chromosomal location of the gene is loved by our examiners. It is present on the short arm of chromosome number 6. We also need to be familiar with the fact that in this kind of a condition, because of the gene mutation, there is going to be too much of iron, and this particular iron is going to get deposited in the liver. There are better ways of having a detection of iron over here, and one of the ways by which you detect the iron in these patients happens to be by a reaction that is going to be given the name of Pearl's reaction. I do hope that most of you should be able to recall the fact that in case of Pearl's reaction, you are going to be using a stain that is going to be given the name of the Prussian blue stain. That's exactly the kind of stain that I did talk about during a discussion of the cell injury topic or the general path videos, which I hope you have seen. And these are going to be the dark blue purple colored iron deposition granules which you find in association with Prussian blue. Patients who are going to be suffering from a condition like hemochromatosis are going to be having the presentation in the form of a classical triad. So these patients can be having the involvement of the liver. Involvement of the liver can be in the form of development of micronodular cirrhosis, and definitely patients are in the future at a high risk for development of hepatocellular carcinoma. Fact number 2, patients are going to be having the involvement of the pancreas. Involvement of the pancreas is seen because iron mediated free radical damage can cause damage to the pancreas, and that can result in development of diabetes. These patients are also known to be having the involvement of the skin, and the skin involvement is in the form of development of more amount of melanin being deposited that is going to be responsible for the hyperpigmentation. So an image based question in the exam can be, for the sake of a contrast, this is an example of a normal hand appearance, and that's the hyperpigmented area because of melanin that you get in a patient who's going to be suffering from hemochromatosis. Examiners love to ask you a simple question, particularly with respect to a male individual. Because of excessive amount of iron deposition, what you find is there is a malfunctioning at the level of the hypothalamo pituitary adrenal axis. This interferes with the secretion of the gonadotropins, and that is what is going to be responsible for causing development of testicular atrophy. But the important thing that I would like you to understand over here is that the testicular atrophy in case of hemochromatosis is not because of, and I repeat that, is not because of iron deposition in the testicular tissue per se. So there is an imbalance at the level of the hypothalamo pituitary axis, and therefore there is going to be the presence of the testicular atrophy. We also need to be familiar with the fact that so far as this kind of a condition is concerned, patients in the joint involvement, and that is going to be a pathology orthopedics link, are going to be having the development of what is going to be given the name of pseudo gout. So you are going to be having the presence of involvement of the liver, you have involvement of the skin, you have involvement of the pancreas, you do have involvement of the gonadal tissue, and you do have involvement of the joint as well, which is going to be seen in the form of a pseudo gout. Not to forget the gene, HFE gene, and the chromosomal location 6p. So that is what we need to have an idea so far as hemochromatosis is concerned. Talking about the next important example of a disorder which is very obvious from the clinical presentation in the form of the development of copper deposition at the level of the cornea, particularly the Descemet's membrane. The condition that I am talking about over here happens to be what is given the name of Wilson's disease. Now Wilson's disease, perennial favorite of your examiners, therefore you need to have an idea that in this kind of a condition, the fundamental problem lies in the fact that there is going to be the presence of an ATP7B gene defect. Remember the fact, an example of a condition in which there is going to be a role played in the defect of copper metabolism, but which is seen because of ATP7A gene defect, happens to be what is going to be given the name of the Kenke's disease. Whereas in this kind of a condition, what you find over here is it is a 7B gene which is going to be affected. The chromosomal location so far as the Wilson's disease is concerned is going to be chromosome 13q. What we have over here because of the ATP7B gene defect is that there is going to be a problem so far as the incorporation of copper with epicellular is concerned. Therefore, what you are going to be having is that there is going to be too much of free copper that is going to be available in the systemic circulation. Now, this particular copper can get deposited inside the eye, thereby responsible for the formation of the Kaiser-Fleischer ring. Remember the fact, Fleischer ring is what you associate with something like keratoconus, that is going to be simple ophthalmology link. But when you talk about the Kaiser-Fleischer ring, it does not interfere. I repeat that, it does not interfere with the vision of an individual. Fact number 2, this extra amount of copper can be responsible for having a deposition in the lens as well, thereby contributing to the development of cataract. That kind of a cataract is what is going to be given the name of a sunflower cataract. We do need to be familiar with the fact that this extra amount of copper can get deposited in the hepatic tissue, thereby it can contribute to the development of an injury which can be responsible for causing development of initially a micronodular cirrhosis and definitely a small but definitive risk or development of liver cancer in the future. So far as the deposition of the copper is concerned, the deposition of the copper in the hepatic tissue can be picked up with the help of special stains, and the kind of special stain that is loved by your examiner happens to be stain number 1. This is what I have talked about with you in the main video section, or scene stain. And stain number 2 that you need to have an idea over here is what is going to be given the name of the rhodamine stain. In fact, it is the rhodamine stain which is going to be giving the copper. It is going to be having a reddish brown appearance, what you can possibly appreciate over here very clearly. Please be familiar with the fact that at sometimes patients can be having a deposition of the copper in the basal ganglia, and therefore Wilson's disease is one of the uncommon yet important reasons for development of Parkinsonism. How exactly are you going to be confirming the diagnosis of Wilson's? That is going to be based upon the fact you have a very sensitive test in which you take a dry liver, and the dry liver is then going to be examined for the presence of copper. What you need to be showing over here is that there has to be a demonstration of more than 250 micrograms of copper per gram of the dry liver weight. Fact number 2, when we are going to be talking about the most confirmatory investigation, that is going to be dependent upon you showing you the presence of extra amount of urinary copper excretion. So the initial one happens to be an example of a sensitive test, whereas extra amount of copper being excreted in the urine of an individual is going to be an example of a very confirmatory test so far as Wilson's disease is concerned. So all those images, particularly these two, are the ones which should be definitely given an emphasis of, because in the recent exams this kind of an image has been asked at least twice, and definitely from the perspective of a future exam, particularly with respect to the name of the stains, the Ornstein stain and the rhodamine stain, that becomes a very pertinent question. Talking about the next important example of a metabolic disorder which the examiners love to ask you, that is going to be in association with the example of a condition that is going to be given the name of alpha-1 antitrypsin deficiency. Let us just recall the fact that you're going to be having a trouble at the level of chromosome 14. Normal individuals like you and me are going to be having the presence of a gene which is going to be given the name of the PIMM gene, wherein PI stands for the protease inhibitor. As and when there is going to be a gene mutation, you can be having the presence of a heterozygous condition given the name of PIMZ, or there can be a defective gene which is going to be given the name of the PIZZ gene. The concept that you need to be familiar with over here is that alpha-1 antitrypsin, which is coming normally from the liver, enters into the systemic circulation, and then it is going to be going inside the lungs. Thereby, it is going to be protecting the lungs from the damage likely to be caused because of elastase. So that is what is given the name of the elastase anti-elastase theory, which I am absolutely sure you are very well aware of. And as and when we are talking about this kind of a gene mutation, this is going to be characterized by a problem at the level of the protein folding. Therefore, there is going to be the presence of the unfolding protein response. Unfolding protein response, as a result of which you are having the hepatocytes which are going to be having the deposition of this kind of a material. I hope you can see this kind of a material inside the cells. Therefore, you are going to be having at a electron microscopic level excessively dilated endoplasmic reticulum. And this excessive endoplasmic reticulum is going to be seen because of the presence of a defective protein in association with the PIMZ or the PIZZ gene. So two troubles that you need to understand over here. One, you have a reduced amount of normal protein. So reduced amount of normal protein reaches the liver, reaches the lungs, and that is going to contribute to the development of emphysema. Particularly the kind of emphysema that you see in these patients happens to be pan-acidic emphysema. And because of the abnormal protein, you are also going to be observing a damage at the level of the liver. So a combination of emphysema along with liver cirrhosis would always be giving you a hint with regards to a patient suffering from alpha-1 antitrypsin deficiency. Now you can demonstrate the alpha-1 antitrypsin deficiency maybe with the help of a serum electrophoresis pattern, or what you can be observing over here is at a microscopic level or histological examination, you could be having the presence of the abnormal protein getting deposited inside the liver cells. In order to confirm whether this particular abnormal protein is actually alpha-1 antitrypsin or not, you are going to be using at times special stains. And when we are talking about these magenta colored granules, these magenta colored granules are going to be having this kind of an appearance. Alpha-1 antitrypsin would be having this appearance as and when we are talking about PAS positive diastase resistant granules. So PAS positive diastase resistant granules is going to be associated with the magenta colored granules that you have in the hepatic tissue, and that is going to be a very much confirmatory finding so far as alpha-1 antitrypsin deficiency is concerned. The next important example of a disorder about which we need to have an idea is going to be a circulatory disorder, and over here you can see the presence of an infarct present in the liver. Now reminding ourselves of the fact that liver is going to be supplied mainly by the portal vein, and definitely less amount of liver is being supplied by the hepatic artery. So major contribution to the vascular supply is through the portal vein, and definitely hepatic artery is playing a role as well. Now, whenever there is going to be a problem at the level of the vascular supply, the kind of infarct that is going to be seen over here is going to be an example of a red infarct. So, particularly in case of hepatic tissue as well as in case of pulmonary tissue, even though there is presence of an infarct, but the infarct is going to be getting a reddish appearance in contrast to organs which are going to be having a single vascular supply, which are going to be associated with the term of white infarct. So, in context of the bowel, in context of, let us say, the spleen, in context of an organ like the heart, we are going to be getting white infarcts, whereas in case of liver as well as lungs, because of the dual blood supply, you're going to be having the presence of a red infarct. One example of a tricky question the examiners can be talking about over here is that if an individual is going to be undergoing hepatic transplantation, an individual who has undergone hepatic transplantation, you just need to be familiar with the fact that this individual is going to be getting the blood supply mainly from the hepatic artery. So God forbid, if there is a trouble at the level of the hepatic artery, the kind of infarct then which is going to be observed is going to be a white infarct. So keep that in mind. Usually when we talk about circulatory disorders affecting the liver vascular supply, you get a red infarct, but especially after a hepatic transplant, because of obstruction at the level of, let us say, hepatic artery trouble, you're going to be getting the development of a white infarct. Talking about the next important example of a trouble which is going to be seen in case of an individual, particularly I can give you a hint that these patients are going to be having the development of hepatic vein thrombosis. Now, as and when an individual is going to be having hepatic vein thrombosis, this is going to be given a special name. The condition is going to be given the name of Budd-Chiari syndrome. Budd-Chiari syndrome. The moment we are talking about Budd-Chiari syndrome, there are going to be certain predisposing factors for the development of this kind of a condition. Factor number one that is being asked in the exam can be a condition like Apla syndrome, the condition that you associate with the formation of anti-beta-2 glycoprotein antibodies in case of females of reproductive age group. Another important reason for development of hepatic vein thrombosis can be a patient suffering from paroxysmal nocturnal hemoglobinuria. You can be having hepatic vein thrombosis in a patient suffering from hepatocellular carcinoma, and definitely the Budd-Chiari syndrome can be seen in patients who are going to be suffering from myeloproliferative disorders. So particularly with respect to the questions that have been asked in the exam, they've asked you the cause of death in a patient having PNS. They've asked you the cause of death in a patient who's going to be suffering from something like the myeloproliferative disorders, and yes, this kind of a condition is going to be associated with a high rate of mortality. So hepatic vein thrombosis contributing to high rate of mortality, this is what you need to keep in mind, Budd-Chiari syndrome. Talking about the next important example of a condition in which you're going to be getting a variegated appearance so far as the liver is concerned. This kind of a condition is going to be given the name of a nutmeg liver. Now understand the fact that when you're talking about the nutmeg liver, you're going to be having certain yellowish areas, and then you're going to be having areas which are going to be having the congestion because of the presence of RBCs. Please be familiar with the fact, friends, that as I'm going to be looking at the diagram over here, this is the area, the darker area actually is going to be because of the presence of the RBCs, and this kind of an area that you need to be familiar with over here is going to be the central area, whereas the paler area is actually the normal hepatocyte lining. So it is usually going to be having the presence of a yellowish color, and this kind of an area is going to be representative of the periportal hepatocytes. So yellowish area, which is the viable cells, are going to be the periportal hepatocytes, whereas when we are talking about the congested ones, which are going to be having the presence of the RBCs, this is the one which is going to be having the involvement of the central hepatocytes. Now this kind of a condition, the nutmeg liver, is particularly going to be seen whenever an individual is going to be suffering from right-sided cardiac failure. So there is going to be what is given the name of the chronic passive congestion or the chronic venous congestion. So venous congestion present for a long duration of time, which is going to be responsible for causing development of this kind of a condition. So the variegated appearance is what is definitely to be kept in mind. Not to forget, paler areas are viable, whereas the darker areas are going to be the non-viable tissue. That is what is to be kept in mind so far as the nutmeg liver is concerned. Talking about the liver tumors, we need to be familiar with an example of a liver tumor that is going to be given the name of hepatic adenoma. The moment we are talking about hepatic adenoma, just about 2 or 3 important things that should be remembered by you. Fact number 1, hepatic adenoma is an example of a benign tumor, classically considered as a benign tumor, but that is an example of a tumor that is going to be seen with a female who is going to be having a consumption of OCPs. Why that particular thing is important for you to understand is because if a female in the reproductive age group, obviously that's a logical thing, she is the one who's going to be consuming the OCPs. If she is the one who's going to be having the presence of a sudden onset of abdominal pain, which is because of the fact that she has had an abdominal hemorrhage, you have to think in terms of something like a hepatic adenoma. I must also tell you over here about the simple fact that as and when we are talking about the hepatic adenoma, as I explained you in the main video section, that you are going to be having the role that is going to be played by the presence of molecules like beta-catenin. So there is going to be beta-catenin overactivity. You are going to be having underactivity of the hepatocyte necrosis factor, and thus there can be an example of a condition given the name of the inflammatory hepatic adenoma. So please be familiar with this kind of a clinical situation. which is going to be given in the exam so far as hepatic adenoma is concerned. Talking about the example of a malignant tumor which is going to be affecting the liver, this is a tumor that we are making a reference to, and this particular tumor is going to be given the name of hepatocellular carcinoma. Now, why exactly do we need to be familiar with the hepatocellular carcinoma is because of the fact that this is an example of a tumor which classically is going to be causing involvement in case of an elderly male individual. Also be familiar with the fact that when we are going to be talking about this kind of a tumor, this is an example of a carcinoma, yet it has got an important tendency that it is going to be using the blood vessels for its spread. At a microscopic level, what you find in context of hepatocellular carcinoma, of course, I presume that a lot of you are familiar with the risk factors. So that can be seen in case of a patient who has had an exposure to something like aflatoxin. Remember the infected peanuts because of Aspergillus flavus. You're going to be having it in a patient who's going to be suffering from a condition like chronic hepatitis B and C. You're going to be having it in case of a patient who's going to be suffering from any kind of a metabolic disorder, say for example Wilson's, hemochromatosis, alpha-1 antitrypsin deficiency. All those things are what are already known to you. At a microscopic level, what you have over here is presence of important finding. Fact number 1, that you are going to be having the presence of trabecular thickness which is going to be exceeding more than 2 cells. Fact number 2, that whenever we're going to be talking about a hepatocellular carcinoma, in this kind of a condition, you're not going to be having the presence of reticulin. So I do believe that a lot of you can make out the presence of increased thickness over here at the level of the trabeculae, and you're going to be having the presence of, or for that matter, absence of reticulin over here, which is going to be very much suggestive of hepatocellular carcinoma. Of course, examiners can test on the special stains which I've talked about in our discussion of the tumor markers with respect to something like hepatocellular carcinoma. So we have got the presence of what is going to be given the name of HepPAR1. That's one important example of a stain that can be asked in the exam. Another important stain about which we need to have an idea, which is going to be given the name of CAM 5.2. Of course, we are going to be talking about the newborn markers, say for example PIVCA, and the classical marker that we always used to make a mention of, something like the alpha-fetoprotein. The only problem, as you can understand, with alpha-fetoprotein is that it is going to be non-specific in nature, whereas these are the ones, the CAM 5.2, the HepPAR1, the glypican 3, the presence of PIVCA, all those are example of the stains or markers which are going to be much more specific so far as the hepatocellular carcinoma is concerned. Now, one important variant of hepatocellular carcinoma that I want you to be familiar with over here is what is going to be given the name of the fibrolamellar variant. Fibrolamellar variant. Now, without having a look at your notes, I would like you to be familiar with the fact that whenever we are going to be talking about the fibrolamellar variant of the hepatocellular carcinoma, the properties that we need to be keeping in mind over here, this was an example of a hepatocellular carcinoma which is going to be equally seen in case of males as well as females. Fact number 2, in case of this kind of tumor, the alpha-fetoprotein levels are going to be normal. Therefore, the marker that we are using for the detection of the fibrolamellar variant happens to be something like neurotensin. Also, fibrolamellar variant acquires significance because of the fact it is going to cause involvement of younger patients, and for important fact, it is going to be having a relatively good prognosis. So far as its association with an infectious organism is concerned, it is not, and I repeat, you need to remember the fact, it is not associated with hepatitis B infection. So, a lot of differentiating facts that we have between the fibrolamellar variant of hepatocellular carcinoma vis-a-vis the classical hepatocellular carcinoma, which are to be kept in mind. Now, at a microscopic level, what you just need to understand over here is that yes, there are going to be tumor cells, and these tumor cells are going to be separated by the bundles of collagen. Now, one interesting question which has been asked in the exam earlier, there is a possibility at times that when you are talking about something like hepatocellular carcinoma, it could be having the presence of certain markers which can also be seen in a patient who is going to be suffering from cholangiocarcinoma. Let me just cite you an example. Say for example, we are talking about a tumor which is going to be having HepPAR1 and CAM 5.2 staining positivity. Uncommonly, that can be seen in case of a cholangiocarcinoma as well. So how do you distinguish between these two tumors then? You just need to be remembering the fact that in case of cholangiocarcinoma, you are going to be having a marker which is going to be CK20, which is going to be positive, and the same marker CK20 is going to be absent in case of hepatocellular carcinoma. So by the help of cytokeratin 20, and I hope you remember the fact that even in case of carcinoma of unknown primary, we do use the presence of cytokeratin 7 and cytokeratin 20 for distinguishing between the different subtypes of the primaries, and that is also useful for differentiating between the hepatocellular carcinoma and the cholangiocarcinoma. So that is what we need to remember so far as the fibrolamellar variant of hepatocellular carcinoma is concerned.